Hello, I'm Locke Meredith. I'd like to invite you to join me on the next Legal Lines. My guest is Dr. Jorge Isaza. He is a preeminent orthopedic surgeon here in Baton Rouge, focuses on spinal injuries. Dr. Isaza is going to talk to us about how he practices his profession, how he goes about diagnosing an injury, how he goes about treating the injury, and if necessary, how he's going to go about doing surgery for the injury. So join us on the next Legal Lines with Dr. Jorge Isaza.
It's time now for Legal Lines Tips with your host, Locke Meredith.
Hello, I'm Locke Meredith with a Legal Lines tip for you. If you have to hire a lawyer, and I hope you don't, but if you do, hire a lawyer that you like, that you trust, and who specializes in your area of need. In these days, with all the laws we have, lawyers for the most part now specialize. They specialize in contracts, defense, business, personal injury, all kinds of areas of the law. So when you interview with a lawyer, ask him, does he specialize in the area of your need? Has he tried the cases? Has he been successful? And of course, how does he charge you? Is his fee hourly? Is it a percentage of the case if he recovers? What exactly does he charge? So my Legal Lines tip from me, Locke Meredith, to you is, if you have to hire a lawyer, hire one you like, you trust, and who specializes in your area of need.
This has been Legal Lines Tips with your host, Locke Meredith.
Welcome to Legal Lines. I'm Locke Meredith, and I'm very pleased to have on the show for the very first time Dr. Jorge Isaza. He is a preeminent orthopedic surgeon here in Baton Rouge who focuses on spine injuries. Dr. Isaza, it's great to see you.
Thank you for having me.
I very much appreciate you coming in. Tell folks a little bit about yourself, your educational background, so they know you know what you're talking about. Yeah, I mean, this is your CV. It's unbelievable.
Oh, well.
It's overwhelming.
I'm getting old, and your CV gets bigger when you get old. But anyway, I started in Colombia, South America. I went to medical school after being in the United States for a few months or so, learning English. And I finished my medical education probably around 1971, 72. 82, excuse me. And then I came to the United States and did a lot of courses to try to get certified my diploma in Colombia to
recognized here.
Correct.
Got it.
Fortunately, my university, Universidad del Valle, was created by Tulane University in South America back in the 60s when the United States needed a tropical medicine department. The next one was in Cameroon, was too far away from United States. So
there was a relationship.
Right. There was a relationship. That's how I ended up here in New Orleans.
Got it.
So I went to orthopedic surgery or residency from 1984 till 1989 and finished there at Tulane and did a fellowship in pediatric orthopedics at Children's Hospital in New Orleans with the direction, of course, of Dr. Dean McEwen, was the chairman there, and Dr. James T. Bennett. After that, I decided to go to spine. And then I did a fellowship with Dr. Whitecloud, who was chairman of the department at Tulane. And he was a spine surgeon, pioneer in this area with Dr. La Roca. And then I did another part of my fellowship in Louisville, Kentucky with Dr. Richard Holt. He was vinculated with the Leatherman Spine Institute there. And then when I got there, shortly after, he decided to be independent. And finished in Louisville, Kentucky as a spine surgeon and moved to Colombia, South America.
And you're certified here, 20 years of education and then certified here in Louisiana and Mississippi.
Yeah, I have license in Louisiana and Mississippi. Used to have license in Georgia, Indiana, Kentucky, but it's hard to maintain all those licenses. Some have some requires of different than others. You need to live there for more than 6 months at a time, and I've devote my full time here in Baton Rouge.
And so a lot of education here in Louisiana and ultimately decided to live here, and you've been practicing here for years.
For years, that's correct. And then I'm clinical assistant professor at Tulane in orthopedics. And also I am invited visiting professor, as they call, in biomechanics at Drexel University in Philadelphia. And I do also teach in South America at the Universidad del Valle as an invited professor.
And also do a lot of research and have written scores of articles.
Yes, I've been lucky to partner with very smart people, so we were able to kind of develop some ideas, and the PhDs at Drexel studied some biomechanics.
And you've actually been involved in the design and manufacture of certain, I'd call it spinal hardware, as I understand it.
Right, as we can talk later, most of the things that I've been really excited about is the motion preservation of the spine. And then yes, I have participated and helped design some devices that allow you to keep your motion. And also some devices like cages that you can put through a small incision, but then you can expand inside the disc itself.
Right. So obviously highly qualified. So let's tell folks what an orthopedic surgeon whose practice is limited to focusing on spinal injuries and spinal ailments, how you do your job. As I understand it, you have to diagnose the injury, you want to treat the injury, sometimes you provide a prognosis, that is how they're going to do in the future. So tell folks how you diagnose a spinal injury.
So let me tell you a little bit. Number one, you don't become an orthopedic surgeon and decided my hobby will be spine. As you see, you have to do this extra year or year and a half or 2 years of training to be able to say, okay, well, I'm a spine surgeon. That's a subspecialty of orthopedics. I fortunately devote my practice 100% of spine right now, and that's what I like to do. So when the patient arrived to my office complaining of pain or problems, then I take a history, which is the most important part of the chart.
And why is that?
Well, because the history will give you, first, lead you to the diagnosis, and in order to treat somebody, you need to know what's wrong. And then it tell you exactly how the problem happened. Some people have tumors. Some people have pain referring to the spine that are not from the spine. Kidney problems, very common. So you have to ask very, very detailed questions about, urinary problems, fevers, chills, and so on. Now, the history gets a little bit easier when they say, no, I just was fine and I fell off a ladder or I had this accident. So, well, then you kind of start getting your attention to what can be. Then you believe it's going to be an injury, not something chronic, progressive that is eating up patient's spine.
Got it. So there's a specific event you can focus on as being the probable cause of the injury or an aggravation of a pre-existing problem.
Correct. If the patient gives you the history that he was having these problems before and is getting to the point that is worse or was aggravated by a particular incident in his life, then we can kind of relate the history with what we're seeing in the physical exam and what we see in the x-rays and other tests.
And so the bottom line is, it's extraordinarily important for a patient to tell you everything that they can recall about their physical condition prior to their office visit with you, what their symptoms are. And their symptoms that they give to you are extraordinarily important in helping you pinpoint what the possible cause is, right?
Oh, absolutely. If you bring the MRI and I don't know anything about it, I can't tell you where to start, what to treat, how to do it.
And so because you focus on the spine, somebody might be having arm pain or pain down into their fingers or numbness or tingling or their leg, and that's important.
Oh, absolutely. The spine is connected to the limbs or the extremities through all these nerves. And if you have a pinched nerve here in the neck, sometimes the patient doesn't have much neck pain. They have just numbness and tingling or severe pain in the arm, and then that's what they call radiculopathy or sciatica or,
And so obviously the patient thinks something's wrong with my hand, but the cause may be up in their neck.
Correct, and vice versa.
And so likewise for the back, because in the lower back you have nerves that run down to the leg, and they might be having foot numbness or tingling or whatever, and they're thinking I must have tore my ankle or something, and it's a back injury.
Correct. So it's very detailed what you need to ask the patient and how you have to examine to come up with the diagnosis that is not the knee, is the L3 nerve that is pinched in the spine, or is not exactly the spine, is the kidney. And you need to pretty much have an idea of what you're looking for.
Got it. And so in addition to that, you do your own physical exam and potentially test, and we'll talk about that on the next segment. This is Locke Meredith of Legal Lines. My very special guest, Dr. Jorge Isaza. We'll be right back.
It's time now for Legal Lines Tips with your host, Locke Meredith.
Hello, I'm Locke Meredith, and I have a Legal Lines tip for you. Remember, knowledge is power. And I want you to know if you're injured, Louisiana law grants you a variety of claims to make sure you're fully compensated. generally chopped up into several categories, the first being general damages. That's going to compensate you for your mental and physical pain and suffering, your scarring, disability, functional limitations, your loss of enjoyment of life. Also, it will compensate your family, frankly, for your loss of affection. It's called loss of consortium claim. Next category is specific damages. Those would be, say, for example, past and future lost wages, past and future medical expenses. You also have a claim sometimes for what's called punishment damages or punitive damages, typically only available when you're injured by a drunk party. Finally, you're entitled to legal interest from the date you file your lawsuit until you're paid and court costs. So my legal lines tip to you from me, Locke Meredith. Make sure you know what your claims are.
This has been Legal Lines Tips with your host, Locke Meredith.
Welcome back to Legal Lines. I'm very pleased to have on my show Dr. Jorge Isaza. He is a preeminent orthopedic surgeon here in Baton Rouge. Doctor, again, thank you for doing the show. Let's dive right back in. You were talking about how you diagnosed an injury, and you indicated what the patient tells you about how the injury happened and what their symptoms were before and what their symptoms are now. That's extraordinarily important, but also that you do a physical exam and you may do some tests. Explain the physical exam, why you do that.
Yeah, the physical exam, like I said, in spine has to be very thorough because you don't only need to examine the extremities because they have symptoms, but also the spine itself. So we go through range of motion of the shoulders to make sure the problem is not in the shoulder or is in the shoulder and not in the neck, or vice versa. And also in the lumbar spine, patients have pain in the hip and in the buttocks, and we need to relate that depending how this pain travels in the distribution of certain nerves, then you can have a hint of where it come from. You do reflexes, you do neurological exam, you know, motor function, how strong the patient. You look and see if the patient have any atrophies. And sometimes we'll have to examine the abdomen. So the patient may have problems, like I say, from the kidneys, liver. You know, the gallbladder hurts people on the shoulder, in the back, on the right side. And then if you don't do the exam correctly, then you may miss that and try to treat something that is not there.
So some of the telltale signs of a spinal injury would be either injury to the reflexes, meaning there's nerve involvement somehow.
Correct.
And then also you will check range of motion to see if it's limited, whether you got muscle spasms and all that. Those are kind of the big focuses that you have.
Yes, you check the range of motion of your cervical and lumbar spine, and you do palpation on every single part of the spine and the muscles there, and you try to localize and pinpoint where the pain pretty much is generating from.
Got it.
And that is important.
The tests, I know, are oftentimes used to either decide that this isn't a spinal injury or it isn't, or it's not what I thought it was, or it is. Tell the folks about the various tests that you use to help diagnose your injury.
Correct. Well, the initial test that we do, of course, is the physical exam, but after that, the simple test that can be done right away in the office is usually an X-ray. So we want to make sure that we rule out big things.
And that's
for example,
going to show you fractured bones, basically.
Exactly.
It's showing you the bones of the spine.
It shows, in general, the bones of the spine and the alignment of the spine. And you can find out sometimes that if the patient has some defects in the bone, like either osteoporosis or a tumor growing, something big.
Bone spurs.
Bone spurs will show, or would this look like a long-standing problem too. And
as I understand it too, the space between discs, you generally have an idea of what that's going to be, and it may reflect a collapse of that space. Is that right?
That's correct. We have, like, for example, the L3-4 disc is big, the L4-5 is bigger, and the last disc is biggest of all. So if you have that kind of change in a certain way, you can kind of suspect that the patient have a herniated disc or ruptured disc in one of the spaces that is a little bit smaller.
Particularly if that's consistent with the symptoms they're reporting.
Correct. If the patient is consistent with have a history consistent with an injury, then we look farther into that.
And it's interesting because we've discussed this, you know, as we age, unfortunately you and I are getting up there now, the spine slowly degenerates. Explain, folks, what that means.
Right. There is a condition that's been described and the terminology probably misused. It's degenerative disc disease.
Yep.
And then we all get that. It's part of being alive, you know, the wear and tear of normal living. And then how do you pretend that a patient that is 15 years old have degenerative disc disease? It's something different. It's a genetical problem, or is it simply some kind of a traumatic event or sports these days that people beat up their
Bottom line is a young person probably ain't going to have that.
Exactly. By definition, that is not there. But of course, the radiologist, when he's reading the x-rays, he will or the MRI, he will say that because that's what it looks like. But you know, you have to correlate the patient with whatever it says or whatever it is in those tests, and that's the most important part of those tests.
And the tests, you mentioned X-ray. There's also what's called an MRI and a CT scan. Explain to the folks what those are.
Yeah. So the first thing is the X-rays, and then after that, if the patient doesn't improve with the treatment that we're going to talk later on, then you certainly want to see more. And the easiest test on the patient and the one that gives us the most information is an MRI, because the MRI gives us different signals that the computer interpret and give us different colors or shades that can differentiate into fat, bone, fluid, muscle, nerve. So you can see
It's a picture.
a lot of things compared to the X-ray that you can differentiate between.
So it's able to show you the soft tissues inside your body, whereas the regular old X-ray is pretty much showing you the bones.
Right. One is like a density test, less density. The other one is the chemistry, and then show it in different colors depending the sequence.
And the CT scan is kind of a combination of the two?
The CT scan is older technology, but it's still very well applied because it shows the bone details better than any other test.
Okay, and so there's also, when those tests are given, oftentimes chemicals used to help maybe identify potential injury sites even more, where they'll inject a fluid. Explain that to folks.
Yeah. In the MRI, they put a chemicals called gadolinium, and enhances scar tissue, tumors, and a lot of the things that go with inflammation. But certain tissues take that chemical regardless, you know, like the uterus and some mucoses and things like that. Now, in the spine with the CT scan, we combine a lot the dye, which is usually based on iodine, and you can see it in the X-ray or in the CT scan, and then it gives you the shadow of the nerves inside the spinal cord. Or you can do arthrograms, so either in the shoulder or in the sacroiliac joints, which is another place that kind of mimics a lot of things going on in the spine, and it's not really there, but it's very close.
Got it. So let's shift gears. So, and you've indicated that those are tests that you would do after you've tried what is often referred to as conservative care. Tell folks what you do first.
Well, the key here is statistically, 90% of the people who have a lumbar sprain or low back pain will resolve within 6 weeks. So taking that into account, I don't want to run a bunch of tests before 6 weeks just because you have low back pain, because if you do the conservative treatment, a little bit of physical therapy and medication, then you get better. And then you save all that stuff, and maybe in 3 years then you need to run it something changed. But if neurologically you have no evidence that you're having something serious, then we start with the simple things, and we don't need to run all those.
And typically that would be pain medication, muscle relaxers, maybe some physical therapy to kind of get the muscles and the body, I guess, feeling better, dealing with the symptoms and such.
Correct. You know, pain medication is not the basic treatment. Unfortunately, we have to give it to some patients having severe pain. But the reason we try to give something that really relieves your pain at the source is what we try. For example, if you have a severe inflammation, I can give you pain medication, but the pain medication is not going to change the inflammation. Anything. But if I give you an anti-inflammatory medication, then you get relief of your symptoms. Okay,
got it. All right, we'll be right back. We're going to pick up where we left off on the third segment. This is Locke Meredith with Legal Lines. My guest, Dr. Jorge Isaza. We'll be right back.
It's time now for Legal Lines Tips with your host, Locke Meredith.
Hello, I'm Locke Meredith, and I have a Legal Lines tip for you. Remember, knowledge is power. And I want you to know, if you're injured and you have lost wages because of that injury, Louisiana law gives you a claim for that loss. Typically, it's going to require medical evidence from a medical doctor stating because of your injuries, you can't work. It's a pretty simple claim. If you had a job before the injury, doc says you can't work from the date of the accident, and 3 months later he says you can work, you can figure out what you've lost in wages. Circumstances occur, however, when the injury results in permanent physical and functional limitations. Now you can't do the job according to the doctor that you could do before the accident. So the question becomes, is there any work you can do, and what is the difference in wages? But the court doesn't just look at what you earned in the past, it also looks at your earning capacity. That is your ability to earn wages in the future, promotions, additional education. So my Legal Lines tip from me, Locke Meredith, to you is make sure you know your rights when you're presenting that lost wage claim.
This has been Legal Lines Tips.
Welcome back to Legal Lines. Again, I'm very pleased to have on my show today Dr. Jorge Isaza. He's a preeminent orthopedic physician here in Baton Rouge, focuses on spinal injuries.
Thank you.
Doctor, let's talk about, so you said you got to diagnose the injury, may run some tests, but you're going to use conservative care initially, which may include medications, physical therapy and such, maybe time even, just to see if it's going to resolve over time. But if that doesn't work, what are the next options?
Well, if that doesn't work, of course, we need to reevaluate the patient slowly again, and then find out if the problem is that the patient have a neurological deficit or the problem is just mainly pain. If the problem is mainly pain, then we certainly go ahead and do some provocative injections and see if we can find out where the pain is coming from. And that's when the epidural steroid injection or the selective nerve block, you block a specific nerve and see if that's
Show us, doctor, on the model what they're doing, because this is a model of the spine, and you can pull it over.
So the main thing is, if you can see, the nerves exit through these holes, and then the injections will be directed to those holes to block a specific nerve. If I put the injection right in the middle of the spine up here and run all this pain medicine there and the steroids, then the patient may get better, but I will have no clue where the pain is coming from.
Because you're numbing basically all the areas.
Exactly.
And you want to numb the area that's causing the pain.
Absolutely. And that's the first thing we do with series of injections. And then if the patient have mainly low back pain and no nerve problem, then we certainly do what is called facet blocks. And then we block little nerves that go by the little joints there. And
show the facets to folks,
The facets
doctor.
are these little cleavage right here.
So it's the bones at the back of your spine.
Correct, but it's the joint, the part that moves. And then you block the nerve that go there, and it's possible to destroy that nerve with radio frequency, like the microwave oven have these waves, but it's at the end of a needle, and then you rupture that nerve, and it takes about 14 months to 2 years to recuperate or reform, and then you may have relief for 2 years or so.
But that's not a permanent fix necessarily. Sometimes you'll have to repeat that.
Yes, you can repeat that because I say they will regenerate.
So you try the injections to deal with the pain, hopefully no neurological symptoms, meaning pain or numbness or tingling into the arms or into the legs or weakness. And let's say, however, that you do have those neurological symptoms.
So you have a neurological symptoms, you look for your MRI again, make sure you review it and find out which nerve is the one. You try to block it, it helps. You see a compression of the nerve in the MRI, then you may be able to help the patient by decompressing the nerve. What
and I think on your model you actually have an example of such a situation, do you not?
Yes, this red part here compressing the nerve. Then if you take these off, which is the decompression, the nerve will be free and you will have less pain.
So the nerve actually, rather this is a disc, and the disc is actually hitting the nerve and causing those problems down the leg. In this case it would be the right leg.
Correct, the right leg, and in this case it's lateral, but it could be posterior and then hit more nerves.
And if it's in the back, in other words, the disc, if it's damaged and it ruptures in the back, is it hitting the spinal cord or nerves in the back or both?
The nerves. The spinal cord ends up here,
okay,
around L1, L2, and then from here is just a bunch of nerves. So everything up here that hits the spinal cord is very serious, because spinal cord, once you damage, you can't recuperate from it. You remember Superman, it never recover. Same thing. So it's important not to allow that to happen, especially if the problem is progressive. You have the nerve, the disc hitting the cord there, and it started having some changes. You want to address that quicker than rather the lumbar spine, that you can take your time. Because
at this point in the lumbar spine, basically the spinal cord goes into a bunch of nerves that they call the horsetail. Is
correct.
The way
and peripheral nerves can heal much better. Now, your question initially also, when you do a EMG, well, EMG, if you have some questions about which nerves exactly are compromised, or if you're looking at maybe the patient have what is called peripheral neuropathy, have diabetes also, and you want to know how much of this numbness is from those nerves down here, not in the spine.
Got it.
Then you go ahead and do that EMG. It's very helpful.
And the EMG is basically identifying the electrical impulses of that nerve in a very specific way, because you guys know basically what parts of the legs or the arms or the body is being controlled by the nerves.
Correct. Then we map that based on that result of the EMG. The other test that is very important is, of course, that we talk about the MRI, but then myelogram. When you do the myelogram, okay, well, the MRI doesn't show exactly what you see in the physical exam. You may go for the myelogram.
Okay.
It's a little bit more painful, more invasive, but it may give you some clues that the MRI doesn't give you.
Okay,
And the last test will be like the discogram.
Right, that's exactly what I was going to ask.
And then the indication for discogram is certainly the patient that has discogenic pain. What that is patient that come with a lower back pain and have an internal disc derangement. And you cannot make him comfortable. All the other treatments, injections, therapy, medications, and everything have failed. Then you have to make a decision, well, what do I do with this patient? Tell him to go away or really try to help him? You know, in spine surgery, there's not such a thing as a cure, you know, or a healed. You know, I'm not the healer.
You try and reduce the symptoms? That's the goal?
We try to patch that, reduce the symptoms, and give the patient a more acceptable lifestyle.
And doctors, I understand it. The disc is basically, and that would be each of these white sections between the bones, are like shock absorbers between the bones. It allows for mobility without pain. And when those discs are injured, that's really what you have to focus on.
Correct. If you have the injured disc and certainly have the pain and doesn't want to heal by itself, then we have to try to figure out how to address that problem specifically.
The injury to the disc, they vary. You can hear about a disc that's bulging, a disc that's desiccated, a disc where the annulus has cracked, or the disc where it's actually herniated. Explain those.
Right. So the disc is that organ that you described that allows the mobility, but then inside there is a little jelly in there, and around there is some ligaments to maintain that in place. And you can rupture those ligaments, called an annular tear, or you can simply herniate this jelly out and compress some of those nerves. So the treatment depends on what you find. Specifically for the disc, well, if the nerves are being compressed and your main symptoms are leg pain, then you need to decompress that nerve, the leg pain will go away. The problems gets when you don't have just leg pain, but you have back pain. And then the back pain is more difficult to treat because, like we talked before, anything can cause back pain, and identify where the source is important. That's where discogram comes handy. And also all these other tests and the history and the physical exam.
And the bottom line is, if you can't solve it with the conservative care and the various injections and such, or the facet burns, then you got to do the surgery. And then in this example, you would cut away that herniation and potentially pack the disc. We're obviously going to have to do this again, Dr. Isaza. I very much appreciate you being on the show.
My pleasure.
And we'll pick up where we left off. This is Locke Meredith with Dr. Jorge Isaza. Thank you for being with us.